Hi, today we are learning about renal disease or pathology of the renal system, renal disease. Now, let's remember about normal structure of the renal and histological microanatomy. You see every nephrons has parts like glomeruli, proximal canal, proximal segment or ganglis loop, distal segment, and collecting tubules. And every nephron localized in the cortex. And only extramedullary nephrons, they are parts of them in the medullary parts of the kidney. You can see it is localized in the medullary parts of the kidney or renal. Microscopically, unit glomeruli has numerous structure like arterial basement membrane, and basement membrane, proximal tubule, pseudo-infiltration. There are visceral epithelium or podocytes. It is around the basal membrane of the capillary. This is afferent and this is afferent arteries, which entering into the glomeruli and including endothelial cells. You can see endothelial cells. Next, our slide, you can see business and also kidney. You can see there is nucleus of the endothelial cells. So it is endothelial cells. This is there are fenestration. You can see also podocytes. Podocytes is visceral epithelium of the capsule, Shumansk-Bowman capsule. And there is the localization of the process of the filtration. There are, you can see endothelial cells, basal membrane, and podocytes. Visceral epithelium or podocytes, it is the same. Renal functions, you know it more, and important of it is the kidney does lots of stuff. RBC production, red blood cells, erythropoietin, calcium metabolism by means of phosphate elimination, acid-base balance, natri and kali balance, and processes both ways into urine. Amniotic fluid, amniotic fluid is mostly urine produced by the developing fetus. No urine, no kidneys, or major malconnections of lower urinary tract. The expectant mother is small for days. The fetus may have problems with renal development. Big ticket items: immunological injury, glomerulus, interstitial tissue, vascular injury or compromise, diabetes or hypertension, and infections upper urinary tract and lower urinary tract. Oh, nephritic syndrome. It's acute injury, multiple possible causes, major acute injury to the glomerular basement membrane. Basic clinical pattern: RBCs in the urine or hematuria, RBC cast in urine, decreased urine output, increased protein, and increased BP. And urinary tests. Material clotted or shed by C. glomerulus, red blood cell cast, white blood cell cast, epithelial cell cast, broadcast, and Guylian cast. Create is a cast of the interior of the duct it formed in. It's clotted in urine and observed microscopically. Clinical syndromes may be nephritic syndrome, nephrotic syndrome, chronic renal failure, or localized pain. Nephrotic syndrome, chronic injury of the glomerulus, and many causes basic clinical pattern proteinuria, it higher than 3.5 gram milliliter, high serum lipids, lipiduria, low serum albumin, and edema. You can see edema, skin pallor with or without facial edema. You can see white pads in a finger. Yeah, you can see fatigue and area and vision. And the ankle or sacral edema. Also, you can see hypoproteinemia and proteinuria. So, also you can see chronic renal failure, many causes, progressive loss or renal function, anemia, bleeding, increased infections, accumulation of nitrogen loss, and pericarditis, uremic frost. Clinical syndromes, you see, glomerulonephritis, general features. Mesangial cell proliferation, war, and leukocyte infiltration, B, basal membrane thickening, regular, linear, or irregular, lumpy. Acute glomerulonephritis, fall of streptococcal infections after tonsillitis, antigen-antibody complexes lodged beneath the food processes, elicit inflammatory reactions, complement deposited, and huge holes in BM. Nephritic syndrome, you can see nephritic syndrome, hematuria, hypoproteinemia, azotemia, and oliguria. Acute glomerulonephritis, large number of immune complexes all at once, collect on the food processes because of charge fixity and focal destruction of basal membrane, blockage of VBT, red blood cells. Acute glomerulonephritis, you can see also in glomeruli. What is it? It is neutrophil infiltratus and acute glomerulonephritis in immunofluorescence microscopy. You can see anti-human immunoglobulin G labeled with fluorescence in identifies the immune complexes granular pattern. Membranous glomerulonephritis, slow accumulation of antigen and antibody complexes, small holes but numerous, and tremendous protein loss. Membranous glomerulonephritis, also you can in fluorescences immunoglobulin G level with fluorescence identifies the immune complexes. Goodpasture syndrome, antibodies specifically against basal membrane, different from immune complex disease, starts as a pulmonary infection virus and make antibodies against pulmonary basal membrane. So cross reacts with glomerular basal membrane. So you can see in clinical, gametoptosis and hematuria, proteinuria, and azotemia. So nephritic syndrome. Membranoproliferative glomerulonephritis. It means that normal cells proliferation in this pathology give it appearance, split basal membrane train tract, C deposition, and alternate papillary. Several types based on what starts it. Also, subendothelial deposits you can see also. Endothelial deposits. 1, 2, 3, everywhere. Minimal change glomerulonephritis. Food processes disease. Children after between 2 6 years follows viral infection, T-cell mediated, tremendous loss of protein nephrotic, steroids helpful. Epithelium with effaced food processes. You can see normal basement membrane, but there are food process or podocytes is destruction. They has not any food flopped. They are flopped. Minimal change glomerulonephritis. Minimal change glomerulonephritis in microscopically, lightly microscopically. You can see how changes the structure of the podocytes. Diabetic nephropathy. Diabetes is a small vessel disease, arterioles. Frequently, all parts of the kidney are involved, so glomerulus most significantly. Chemistral Wilson, non-enzymatic glycosylation of proteins. Diabetes is vascular disease. Atherosclerosis, accelerated arterioles and retinal blindness, gangrene, renal failure, and neuropathy. Non-enzymatic glycosylation. Glucose sticks through and alters all sorts of protein. No way of getting rid of the modified protein. Beams, especially small vessels, narrow glomerular basal membrane becomes inefficient, loss of protein, so renal failure. Can call renal failure. Immunoglobulin A nephropathy. Mesangial deposits of immunoglobulin antibodies you can see in an immunofluorescence microscopy. Multiple episodes of hematuria, more common than once thought, and transplant the treat of this. Tubular and interstitial disease, acute tubular necrosis, pure tubular cell condition, or ischemia or toxic. Interstitial pyelonephritis. It may be etiological agent, more maybe toxic agents, and acute tubular necrosis, ischemic or toxic disease of epithelial cells. You can see in the red. You can see this is parts of necrosis. And did epithelial cells fall off the tubular basal membrane? They clog the tubules. No urine output, loss of concentration gradient. And two types, ischemic type and toxic type. Pyelonephritis, inflammation of the interstitial tissue, and infectious, maybe etiologic factor or toxic or immunologic. Acute pyelonephritis, bacteria stem from the urinary bladder and gram-negative rods, blood, pus, and cast in the urine. These folks are sick. You can see mixed picture, arteriolosclerosis, pyelonephritis, and glomerulosclerosis. You can see, and in the patients, you can find out hypertension of them, but not invariable. Bacterial pyelonephritis, actually two ways, bloodborne or ascent from bladder. And ascent from bladder, yeah. And bloodborne, direct infection of renal tissue, predisposing factors, ureteral reflux, lower urinary tract obstruction, diabetes, vascular disease. Ureteral implant angle, lack of sphincter action, reflux, congenital problems for children, surgical correctable. Chronic pyelonephritis, you can see in the macroscopically. You can see large, no large, it is smaller than um, than normal healthy kidney. And chronic inflammation, round cells, tissue destruction, fibrosis, you can see diabetes, hypertension, repeat infections, and thyroidization. Thyroidization you can see on the microscopically the cells like thyroid. So thyroidization is mainly characterized chronic pyelonephritis. Renal papillary necrosis, disease of the papillary, inflammatory and vascular causes, diabetes, analgesic nephropathy, chronic pyelonephritis. Cystic disease, polycystic renal disease, growth of tubular epithelium causes cyst formation. Cysts accumulate fluid and squeeze the rest of the kidney out of existence. Adult inguinal forms, you can find out. Tumors of the kidney may be benign or malignant and primary with metastatic. Renal cell carcinoma arises from tubular epithelium, likes to spread by way of blood vessels, widely metastatic and painless hematuria. Golden yellow with areas of necrosis. Golden yellow with areas of necrosis. Wilms tumor or nephroblastoma. It is embryonic appearing tissue and two cell types, stromal element and little tubules. Little tubules you can see. Lower urinary tract infections, stones or cancer. Bladder infections, very common, host bugs, Escherichia coli, also gram negatives, ureteral trauma, catheterization of the bladder infection, or paraplegics especially. Kidney stones, most are formed of oxalate crystals. You can see, yeah, it is. There are stones of the kidney. Pyelonephritis, it can called pyelonephritis, obstruction pyelonephritis, obstruction types of pyelonephritis, and it is very painful. And ureteral dilatation can called. Kidney stones, you can see in my microscopic large calculus, yeah, and hydronephrotic kidney, thinning of the cortex of the kidney, you can see also. Papillary transition cell carcinoma, you can see in microscopically papillary transition cell carcinoma. Thank you for attention. Bye.